So we'll get started. My name is Sayfo. I'm an interventional cardiologist from Texas. I will not try to speak in Spanish after following the two doctors who are very fluent in Spanish, but I will try to speak slow English. So I was asked to give a talk over the next 20 minutes about two different topics that has something in common, which is the mechanical continuous suction or thrombectomy, both in the coronary, in the pulmonary artery, and in the vein system. So we'll start with the coronary artery. The question is, why do we care? When you have, we've seen it as an interventional cardiologist, when you have a higher thrombus burden, that increases the risk of MACE, stent thrombosis, and we'll call it no reflow. And nothing worse than doing a beautiful job fixing a blockage, especially in the case of an emergency, an ST elevation MI, to have to come back in a few hours or within 24 hours because your stent thrombosed. And when you have a no reflow, there is multiple trials to show that the survival rate for those cases actually worse. So we care about the thrombus burden. We care about what to do with it. And of course, over the years, there were so many trials back to back to show benefit of taking that clot out, till a few years back when the total trial came out. And when you look at the total trial, where they compared people with ST elevation MI, and you do either a traditional intervention with the balloon angioplasty and stent versus taking the clot out, there was no significant difference between the two groups from mortality or cardiac benefit. The issue that was of a concern is the fact that the patient who got a manual thrombectomy ended up with a higher stroke rate. So because of that, the guidelines has changed, and this is the guidelines that we were taught. This is the guideline that's been teaching the fellows and the resident and the trainee for the last, 10 years or so, till 2021, when that changed. So the guidelines saying a routine thrombectomy in a coronary intervention is not recommended. And I want to emphasize the word routine. That still does not mean every patient you treat the same, because some patients require some kind of thrombectomy when you have a large thrombus or you get a no reflow. So, but a routine use is what we call a class 3 indication in the American guidelines. So when do we expect thrombus? We've seen cases yesterday. I don't have any example of them on this slide, but we've seen a couple of cases from the physician who presented yesterday that showed some ectatic vessel. And we know those with ectasia, when the vessel dilate and have something called positive remodeling, and the vessel that's supposed to be a 3 to 4 millimeter is 6 and 7 millimeter. Those patient has a higher rate of thrombus burden. But also we see it in acute coronary syndrome with ST elevation MI. We see it in non-ST elevation MI, acute coronary syndrome, when the patient stays home for a while before deciding to come to the hospital. And I think that's something to if you've been doing this for a while, we've learned it the hard way. When you have someone who's been having chest pain for a week or so, and you go in and do a balloon angioplasty, and basically you have no flow distally. We see the same thing with the SVG intervention, someone who come with acute stent thrombosis, and in the case of a no reflow. So, this is the differences between the traditional manual thrombectomy that almost every cath lab has, and we've been using it for a while, and the continuous mechanical thrombectomy. And this is why we'll look at some of the data show that there's significant difference in this two technology, even though we have not compared them head to head. So when you look at the, so when you look at the mechanical, manual thrombectomy, the more blood you fill in the syringe, the pressure, the suctioning pressure, the negative pressure goes down. So by the time you're taking that catheter and the syringe out, you basically have no suction on the tip of that catheter. So unless you're clot has already transmitted through the microcatheter back to the syringe. If you had it at the tip of the catheter, by the time you take it out, you may end up losing that catheter. So if you lose it in the coronary artery, no harm, no foul, because you have not caused any issue. But if you lose it outside the guide, and it can dislodge and go to the brain and cause a stroke. Where with the continuous aspiration, you see continuous suction that's almost negative 28 or 29, and that does not change by how fast or how slow you're proceeding. And we see this in the graph, and you see a very stable continuous suction in the continuous mechanical thrombectomy, where in the manual thrombectomy you lose that. Of course, that doesn't mean every case require CAT RX, because this is the only device available right now in the US for a continuous mechanical thrombectomy. There are certain limitations of the catheter, and I think that's important to recognize. The catheter can fit in 6 French sheath, but cannot go through a guide liner or guide extension. It cannot go with 2 wires in the body, so it has to go 1 wire. So if you had to go with 2-wire technique, you require 7 French or 8 French system. So this is just basically a benchmark kind of testing to show how it works. And when you look at it, something very unique about this device is the tip. The tip is not circular, it's pivot. What it means is, if you look at it, it has a bigger area, and this is why we think it's the clot has, when we're using it, we don't see the clot at the tip of the catheter, which actually help suctioning that clot further into the tube. So step by step, how to use it. Again, it's an 014 catheter. So it's an 014 wire. It's an RX, rapid exchange. So you can use your traditional 180 wire. You turn it off when you hook it up, and you turn the machine, the console on. In the console, you'll see 4 different lights that you have to have them all up and running before you be able to put the catheter in the body. When you put it in the body, the recommendation is to put it proximal to the clot and turn it on and just sit there for 30 seconds. The 30-second helps you doing 2 things. Number 1, it helps creating that negative suction. It requires some time for the machine to create that negative suction. And 2, you want to have the tubes all the way to the canister filled with the blood, so you're able to see the dripping. That'll be your guides of how forward you need to push. You have to go back, and then slowly you push forward. And if you lose that dripping in the canister, what that means, either you sit there, give it 5 to 10 seconds so the clot may get dissolved and pushed into the catheter, or you may have to pull back to a free flow segment and then push forward. The biggest mistake we see is someone doesn't turn it on until they are in the clot already, and what ends up happening is you're pushing the clot forward. Or the second mistake is you turn it on, you see the suction, you push forward, and you lose that flow. And what happened, you have to just sit on it, and instead people just push it forward. And when you do with that is actually you continue to push the clot forward. So it requires to be a little bit more patient. And again, this is just to show you how the thrombus can change in shape. And this is when you have a no flow versus you have a steady flow. If you have a steady flow, that means the clot has removed, or you are in a free flow segment. You can push this catheter as in a small vessel, as small as 1.7 millimeter. We've used it in a PDA, we've used it in a distal LAD. Of course, if you have heavily calcified vessel, that may be challenging. A couple of examples of, so the one on the bottom is showing an RCA. And the reason I want to show this one is for 2 reasons. Number 1 is showing how tortuous that RCA is, and the catheter was, we were able to deliver it all the way to the distal RCA. And the second thing is where the occlusion looks like on the first angiogram, versus where you really have the plaque rupture is completely different. And that's a theory that we're working on in our institution to prove that possibly the using with CAT RX will help us utilize less stent, because you can identify where the acute plaque rupture is. And I'll show you another example. This is just an LAD straightforward picture. This is an example of SVG, and I think this is important because this is a nightmare for any interventionist who does acute myocardial infarction on call for STEMI. So you take a first picture, you see this big thrombus sitting there. It's a class 1 indication. It's a requirement to put a distal embolic protection device in every SVG intervention. Unfortunately, in this case, you do not see it. You need to see the vessel distally. So in this case, what we did is we proceeded with a CAT RX, and you see slow suctioning here, and you can see the clot actually coming out with the suction. When the clot, and then afterward, this is just a picture afterward, and you can see it's actually the whole the graft is completely clean, and the plaque rupture is actually very, very distal and very discreet. So if you just went the old-fashioned way, either you balloon and you shower downstream and you lose the vessel, or you end up stenting from here all the way down, versus in this situation, the only stent that required is a very short stent. And that's the final result. We haven't lost any distal flow. So in 2019, this is a multi-center trial that looked at 59 patients very early on. And they were able to achieve 93% of TIMI-3 flow with CAT RX alone. It was pretty fast procedure, 35 seconds, and the stroke rate is 0. That's what's kind of triggered all this interest of this device. There was an early on, and then another trial came out, which is bigger, showed the same kind of stroke rate, but the TIMI-3 flow was a little bit lower. And when they investigated why that happened, and we'll see that also with the next trial, is that people were not used to how to use the CAT RX. There was no guidance of how to use it, the technique. And a lot of people, when they cannot pass it through, what they do, they go with the balloon first, which basically caused distal embolization. But both trial kind of showed that it's safe. So a big trial came out. It's called the Cheetah trial. This is a landmark trial that has really changed the practice. It's a 400 patient, 25 side, and they did not say ST elevation in my patient. They said high thrombus acute coronary syndrome, which make a huge difference because not every ST elevation in my has a lot of thrombus, and nor every non-STEMI does not. So what frontline you do with CAT RX, this is what they looked for. They looked at the safety and efficacy trials. They looked at a 30 days major adverse effect, cardiogenic shock, readmission, heart failure, etc. But also they looked at a 60 days outcome, which is very important. And this is where really, this is why everybody was waiting for the result, because they want to see if it still have the same, when you have a bigger volume, or you still have a lot of stroke or not. So this is the result, and the result was very, very interesting. So 30 days free of MACE, 96.5, those are sick patients. Just to make a quick comment, even though it was a high thrombus ACS, 90% or more of those patients were ST elevation MI. So they are sick patients. And again, TIMI-3 flow at the end was 97%, and a complication from the device was 0. So when you look at it, and this is something I want to talk about it for a minute here. So first of all, the disembolization rate when they do a core lab education was 0.75, which is less than what expected. And this is very important. I think this is something we completely forget about, but as an interventionist, we've seen it. You've had a patient or someone, one of your partners or one of your other colleague has the patient, they do a nice job on the ST elevation MI, and they'd say, great, we saved your life. The patient heart function never recover. And when you do a stress test, a nuclear stress test, you see this large infarction that will never recover. And the question is why? And this is why. It's what's called a myocardial blush grade. And there's a very interesting trial when they looked at basically divide them to two segments. Either you have MBG 0 and 1, basically really don't have any blush, versus 2 and 3, where you have a nice blush in the myocardium, and there's a significant difference in mortality. So when you have a nice epicardial flow, but when you take the last picture, you don't see any blushing in the myocardium, what that means that you have a lot of distal emboli that cause basically the myocardium to die. So the results show that it's safe, it's effective, it's easy to use. Really, learning curve is very, very simple. And for the cath lab staff, it actually become very routine things for us. Every ST elevation MI, it's automatically, they bring it to the room. They don't open it though. They bring it to the room just in case we need to use it. And if I ask to use it, it takes them less than a minute and a half to set it up. So it's pretty quick. So what's the conclusion from this talk? The conclusion is no reflow is a serious problem. It is not something that we should ignore. It is a nightmare. There is an algorithm to look at how to treat no reflow. And I would recommend the two things that I would recommend to do when you have no reflow is one, to IVUS, intravascular ultrasound. I think that's crucial in every no reflow to decide if it's a distal dissection, distal embolization, or stent thrombosis. And number two, if you're going to do a vasodilator, I would really recommend to inject the vasodilator through a microcatheter to the distal vessel bed instead of just from the proximal part. Of course, high thrombus is a problem. Mechanical aspiration is safe. And of course, we need more trials. I mean, 400 patient, it's a decent trial, but in the cardiology world, it's a very small trial. So finish this part with the presentation. A 76-year-old female came with non-STEMI. Her echo showed ejection fraction 25%, multivessel disease, very sick, ill patient. The surgeon said, will not do open heart surgery. She will never recover. Of course, she's also legally blind with a creatinine of 3.5. So angiogram diagnostically showed an LAD of 70%, OM2 of 100%, and an RCA long lesion, which is the healthier, most suitable for PCI. So we bring her in. This is just diagnostic angiogram. The goal was to do an IVUS-based intervention to avoid contrast. So this is actually from her first angiogram. When we brought her back, we did not take any angiogram. What we did, we just put a wire, and we put a Boston Scientific IVUS, which is a slicker IVUS than the traditional IVUS. And you can see, it's actually bigger vessel. It's around 3.5 millimeter vessel in the proximal part and around 3 in the distal. So it's a decent vessel. All of a sudden, we noticed that there's actually damping and pressure, which it's a concern. And I think if you have someone who's controlling the manifold to inject contrast, you have to be careful when that happens and just make sure they don't inject. So the first thing we came to our mind is, are we, deep in the vessel, or is this a problem? We recognize right away, we asked for the ACT result, which came as 120. And as you know, it needs to be 250 or more. So that was a nightmare. So we know that there's stent thrombosis there, or a vessel thrombosis. So this is what happened. We cleaned it up, and then we took picture, and you can see went from a stable, straightforward, easy, simple intervention to a really complicated situation. I mean, the patient was kind enough not to crash on us because, EF at 25%, multivessel disease, and she lost her biggest vessel. She was very hemodynamically stable. We got a cat RX. Again, you turn it on, you wait slowly, and you suction. And this is what the clot we took out. This is how we felt when we had this picture, and this is how we felt after the cat RX. So we had a nice flow there. End up with a couple of stents, post dilation 3.0 and a 3.5 stent, and then post that with a 3.75. And this is your final result. Again, you see a nice blush there. That's what we looked for. So we made sure that we have not messed up the distal flow. Okay. So we'll move to talk about PE and DVT. There, PE clot, clot in the pulmonary artery and clot in the venous system is completely different than the coronary. It's a completely different ball game. Is different acuity, and I think Dr. Henry has mentioned did a very nice job talking about the PE prevalence and treatment option, and I think this is maybe just a continuation of his talk. So this is why we care. This is why we care about PE. If you talk to your family members, you will find someone in your family had a blood clot somewhere in their life. And the question is, when they have a pulmonary embolism, have they survived it, or have they just still dealing with the consequences? But if you have a massive PE with resuscitation, it's a 65% mortality. It's not small. And if you look at overall PE mortality, it's around 17%. This is where you have a chronic clot that you don't take it really quickly, end up having something called CTEPH, which is a pulmonary hypertension from old thrombus. But even when they looked, this is not a recent data, but when they looked early on, they found that more people die from PE than all of those three things combined. And those are all important topics and healthcare problem, but you have a lot of education and a lot of awareness about those, but you don't have anything about this. I've met recently a very nice young lady who actually was the United States and the world champion for swimming. And she quit her swimming career because she had a PE after her second silver medal of Olympics. And because of that, at 24, she quit being an Olympic swimmer. So it can be a significant problem. And this is why we care also. Where should we intervene? I mean, every patient comes somewhere here in this area, and when a patient just have a blood clot and RV dilatation and a little bit tachycardic, blood pressure is stable, we just kind of ignore how sick they are because they look fine. We always think when people is hemodynamically compromised is people are very sick, people are crashing, people on pressors. But if you ignore that, what end up happening, the right ventricle fails so badly that you can't push blood to the left system. And because of that, this patient become called a spiral of death. So they lose the ability to continue pushing blood through. And if you don't catch them before this turn, this usually mortality rate goes from 11% to 65%. So this is, again, how you identify those patients. So for low risk patient means patient has a clot that doesn't cause any RV dysfunction, troponin is negative, hemodynamically stable. We actually send patient home on those. We don't admit those patients. Those patients go on anticoagulation. We send them from the ER. If you have, and then those massive PEs that are the really sick patient with the low blood pressure that you give them IV TPA. And I would recommend if you're going to start a program, to have a conversation with your pharmacologist, your pharmacist, because you need to know if you have a system in the hospital, when you ask for it, they can give it to you really quickly. We learned it the hard way. We asked for a TPA once, it took 55 minutes to get it. It's not an easy task. And then almost 55% of patients comes what's called intermediate high risk or intermediate low risk, which is basically a patient has a significant size clot, but at the same time, they have blood pressure that's stable, but their heart rate, their respiratory rate, their oxygenation is not great, but they're responding to fluid, they're responding to management. Positive troponin, RV-LV ratio above 0.9 is what identify those patients. And the guideline says if you have a submassive PE that failed medical therapy, it's reasonable to do a catheter-directed TPA. This is the latest 2019, and the 2022 European guideline has not changed. So let's talk about treatment options. You know, there are, right now in the United States, there is two different pathways to treat this. You have a catheter-directed TPA, or you have a thrombectomy. And thrombectomy, there's so many companies. I'm going to talk about one device in particular. It's called the Lightning Flash from Penumbra. It's a continuous suction. Again, it's a different tip. Remember the pivot tip for the coronary, because that's a smaller vessel. This is a 16 French catheter. You put in the vein, you cross to the lung, and it's guided by a computer. This is not an AI, this is a computer guided. What the computer tell you, it give you a hint if you are in a clot, you're against a wall, you're in a free flow. So you'll be able to direct your catheter the way you want it. It just help assisting you with the flow. It's 8.4 more powerful than the FlowTrieval 24. FlowTrieval is a manual aspiration, had the same concept of what we talk about for the manual aspiration for the coronary, but it's still a good device for certain cases. So this is how the catheter looks like, how the package is. This is the computer system that you hook up to the canister. This is the device. This is a double curve, and there's only one curve. And also inside the device, you will have a 125 5 French micro catheter that will help you go to a certain branches. This is a quick example. You take a catheter, select, take a picture, the wire is further out, you push it further down, you deliver the device, you suction the clot, and this is the clot what you took out, and you have a nice flow. So the Strike PE, it's the latest data from Penumbra, and it's a trial that actually aimed to look at 600 patients. It started a couple of years ago, and will continue for a couple of years from now. It's just looking at a 600 patient enrollment. That's pretty big volume, and it's all looking at patient with submassive PE. They've sent 2 publications so far, 30 days and 90 days. And the first 150 patients, actually, they used the 12, Lightning 12, not the 16, which I think now the data will change. So the 600 patient, 55 global, it's looking at not only outcomes in terms of safety or RV to LV ratio, but what they changed here, they're looking at the quality of life, which I think is important. Again, this is the 12. We still use the 12. We still use the 8, but now we really changed to the 16 for the PE. I only use the 12 and the 8 for the DVT. 16 is my to-go device for the pulmonary embolism. Again, RV to LV ratio in 48 hours, like a standard, this old standard safety measures that all company does. And this is the unique thing, is the quality of life. So what I'll comment about here is two things. The thrombectomy time is 33 minutes and ICU stay is 38%. So when you look at other devices, I would say it's much faster to use a flash 16 for PE. Comparing other devices, it's just because it's a continuous suction. You don't have to take the catheter out or in and out to clean it up. The continuous suction will clean it up as you go. And when ECOS, with ecosonic fragmentation from the ECOS from the Boston Scientific, we send 100% of our patients to the ICU, where in this device, we send them on a telebed. Again, RV to LV ratio, in 48 hours, there's a significant drop. Major bleeding and complication was 2%. Again, this is just, so I'm going to finish up with 3 cases. This is a 54-year-old male, had no past medical history. And this is what you're going to see when you start a PE program, that you're going to deal with younger and younger patients. My youngest patient is around 17 years old. My oldest patient was 98. But you'll see a big spectrum there. I had acute shortness of breath for 3 days, came with hypoxia and tachycardia. This is their EKG. Really nothing unique about this EKG, just sinus tachycardia. And this is your most important testing, is the CT scan, which you see the saddle PE. A couple of things we look at in the CT scan. We look to the size and the location of the clot. We look if there's any sign of chronicity. We look at RV to LV ratio, and of course, we look if there's any infarct. With the echo, we look at 3 things. We look at the RV to LV ratio, and then this echo, the reason I show this echo is because the sonographer did not really do a good job. And it's really emphasized the importance of having a conversation with your echo person, because if they don't do a good job doing the echo, you're gonna make a wrong decision. So we had the tech to go back and redo this. If you look, you can see the aortic valve here. And for the cardiologist in the room, that's not a true apical 4. So that's why the RV looks smaller. But when we went back and we did a true apical 4 without the aortic valve here, it actually looked, the RV to LV ratio was 1.2. Anyway, this is the picture. You can see they're pretty close to, by the time we got to the patient, what actually happened, the patient require more requirement on oxygen, 35 liters of oxygen. And if you notice here, the clot here is completely occlusive, looks completely different than the CT scan. See how the CT scan looks? What happened when you put patient on heparin, that's why you have some patient, after you start them on heparin, they may get sick, is the middle segment here kind of dissolved and it pushed it to both sides. So this has become occlusive on the right side, become occlusive on the left side. I don't see any, saddle anymore. So anyway, you take the clot out on both sides and you have a nice flow, nice blush on both sides, and patient leaves with 4 liters of oxygen. And when you take this clot, you'll see a difference in the type and shape of clot, depends on the device you're using. With mechanical thrombectomy, continuous mechanical thrombectomy, you have this continuous suctioning of the saline, of the fluid, so the clot looks much smaller than when you do, like, for example, Inari. And also you see the whitish and the darkish color, which reflect, dark is acute, whitish is chronic. Case 2, 63-year-old female came with 3 days of shortness of breath after knee surgery a few weeks ago. Again, this is a very common story. We hear it over and over and over. And we're learning now which surgery has high risk for DVT and PE. And believe it or not, it's not orthopedic surgery. It's actually plastic surgery. Tummy tuck has the highest. That's 20% of patients can get DVT. So anyway, blood pressure is very stable. Heart rate is a little bit up. So the respiratory rate is a little bit up. Heart rate is a little bit up. Setting a low 87 in room air. So when the ER doctor calls you, they're going to call you, this is normal. Patient is stable. That's really not stable patient. Again, PE showing CT 1.1. And this is the picture. Again, if you notice here, this is a picture should have been a little bit better. I would recommend pushing the catheter further up. I usually do my first picture with a pigtail. This is one of my partners who did this case. And the second thing you want to talk to your patient to hold their breath. Because if you're doing a digital abstraction or DSA and they're not holding their breath, you can see there's a lot of motion artifact. But nonetheless, you can see that the left lower lobe has no flow here. And this is after we did a thrombectomy. And now the catheter is more selective. You see a nice flow to this lower lobe. Again, here is the clot sitting right in the middle. Better picture here. And this is afterward. You can see the middle lobe kind of opened up where you don't see it here. So two picture of this to show you the difference between the clot. This is the acute part of the clot, very small amount. And this is the amount of clot that's chronic. Majority of the clot we take from the lung has some white part of it because they come from the DVT. Last case before finish, this is a quick DVT case. This is another usage for flash 16. 74-year-old came with a right lower extremity swelling, venous ultrasound showing DVT. Patient had early sign of flommesia. So we went in. I do 100% of my patient on their prone on their belly. We go from the popliteal vein. We upgrade to 16, or actually we upgrade to 18 sheet. And then you take a picture. And what's interesting about this patient is actually this patient has a dual femoral vein system. So this is not a clot in the middle. That's what we thought initially. It's just clot here, clot there, and then clot comes back. It's actually there's two veins here. And we went in with the thrombectomy, and you can really appreciate that this patient has a dual common femoral vein, and this is wide open all the way there, and this is pretty acute clot. Thank you.